Within the basic types of cardiac pacemakers, we can distinguish between two kinds of single-chamber pacemakers, which in a simplified way of thinking can pace and sense only the right atrium, AAI pacemakers, or only the right ventricle, VVI pacemakers. Currently, frequently implanted dual-chamber cardiac pacemakers can pace and sense both the right atrium and the right ventricle, which are the so-called DDD pacemakers. We should also mention pacemakers which are currently only rarely used, which have the ability to sense depolarization of the right atrium and to sense and pace the right ventricle. These are the so-called type VDD pacemakers. Construction schematics of individual types of cardiac pacemakers are presented in panels A to D of the figure. The letter markings of individual types of cardiac pacemakers presented on the previous slide are associated with the basic modes of their action. However, as you can guess, each of them can be reprogrammed to work in a different way, but not in any mode, with the exception of dual-chamber cardiac pacemakers, which have the largest possible number of modes among cardiac pacemakers. The pacemaker mode of operation is usually determined by a four-letter code. The first letter indicates chamber or chamber spaced. The second letter denotes chamber or chambers sensed. The third letter indicates the response of the device to the sensed event, while the fourth letter indicates active or inactive rate modulation. For example, a conventional VVI cardiac pacemaker paces the right ventricle, senses the right ventricle, while in the case of sensed ventricular depolarization before a given lower rate of pacing, it inhibits pacing. However, if within a specified period of time resulting from the programmed lower rate, usually about 1 second, there is no depolarization in the ventricle, then it will deliver a pacing impulse. It is important to emphasize that properly programmed DDD cardiac pacemakers allow synchronization of atrial and ventricular contractions, and thus prevent the development of pacemaker syndrome. The symptoms of pacemaker syndrome are due to mistimed atrial and ventricular contractions. Currently, DDD cardiac pacemakers constitute the basic group of pacemakers implanted in everyday clinical practice. Both in patients with sinus node disease as well as in the group of patients with atrioventricular block, these pacemakers are the first choice. The main exceptions are VVIR pacemakers, which should be implanted in patients with atrioventricular conduction disorders with concomitant permanent atrial fibrillation. It is worth emphasizing once again the importance of programming appropriate atrioventricular delay or appropriate algorithms to minimize right ventricular pacing in patients with sinus node disease and in patients with intermittent AV block to prevent unnecessary right ventricular pacing. In addition, I would like to mention once again that in patients with chronotropic incompetence, it is important to activate the function which increases frequency of pacing in response to physical activity. This is known as the rate response function. It should be remembered that in a patient after pacemaker implantation, pacemaker activity may not be visible on the electrocardiogram. This may result, among other causes, from the programmed lower rate below the rate of current sinus rhythm. In some cases, we can observe pacing artifacts only before the P waves or only before the QRS complexes. The last possibility in dual-chamber pacemakers is the presence of pacing artifacts both before the P waves and before the QRS complexes. In pacemakers, programming of unipolar pacing polarity is typical, which results in the presence of high amplitudes of pacing artifacts. In contrast, In ICD devices, typical bipolar pacing produces a small amplitude of pacing artifacts which can be almost invisible.